Good morning, good afternoon, and good evening, my friends. Today, I have the pleasure of having my friend Ruby Woodward on the show today. We're going to be talking about chapters 19 and 20. 19 and 20? Yes, 19 and
hmm
20. So, accidents, injuries, poisonings, and external causes. So, thanks for being here, Ruby. I really appreciate it.
Thanks for the invite.
And you're wearing your external cause code T-shirt today too.
I am.
Um,
So we'll see if you guys can see. We're talking about sucked into a jet engine
that happens more than we would like to. Usually not a person. I hear it happens with birds more than
very
people,
commonly.
but it could. In this day and age, I'm not surprised by anything I hear anymore. I didn't know that laundry soap was a problem. So I mean, there you go. Um, Today is National Waffle Day and National Peach Pie Day. So I think my husband is going to be thrilled. He might be having peach pie for dinner. He does that from time to time. And, you know, men, they don't put on weight like women do. So he can get away with that, she says, salty. So, Ruby, how do you decipher with the seventh characters? How do you understand the seventh characters when it comes to injuries that we have to describe?
Excellent question. One of the first things that I do is I remove that horrible word that says active treatment. And when I talk to a provider, I never talk about active treatment because, from a provider and a clinician's standpoint, they consider themselves to be actively treating a patient the entire time they're treating them until they've discharged them from service. So I look at the active treatment, as I've evaluated the patient, I have determined a diagnosis, and I have initiated treatment. That is A. And then once I have done those steps, it then becomes the subsequent. And based upon whether I'm dealing with fractures, whether I'm dealing with dislocations, which of those subsequent codes that I use. I think one of the problems that we have with the seventh character is we don't have something that's kind of in between, particularly from a fracture perspective. So we have those patients that have fractures, um, that they aren't quite healing yet, but the provider is not documenting that they have a delayed union or a non union. They might not be quite out there, but our only option really that I see is a D. I don't
Mhm.
see, if they're not changing their course of treatment, I don't see that I would revert back to an A. The other one that I personally have trouble with are those patients that we have seen them, we've established them, the diagnosis, we've started to manage them, and maybe a few weeks down the line, the fracture moves.
Mm.
So they aren't really healing, but nothing happened. The fracture has moved. Am I an A or am I a D? From an office perspective, when I take them to surgery, we know that it becomes an A again. And it's actually a question I've had out to coding clinics since January of this year. So, to find out, what do we do with those types of patients? How do we categorize them?
And people in
From
orthos, they struggle with this all the time because just like you said, that seventh character, I personally think that the term initial and subsequent is misleading from a coder's perspective as well,
hmm
because Um, I always tell the little story about my mom. She fell, she fractured her wrist. We took her to the emergency department. They diagnosed it with an A. They said, but we can't fix it. You have to see the orthopedist. So she goes to her orthopedist, who again concurs that diagnosis, but wants more imaging before making a decision how she's going to treat it or he's going to treat it.
hmm
Then it's still an A. And then they come back in, and the doc says, well, I feel like it's a surgical case. So I can't do it in the office today, and I've got to schedule you. So we're still in A, and mom's fracture is over a week out.
hmm
Um, and then after the surgery, mom goes into, she wears the cast for 6 weeks, but then she starts physical therapy because it's healing. So it's subsequent. Even if it's the first day of physical therapy, the fracture's healing. We're just making sure that everything's moving again now and bending and
hmm
doing what it does. And So I like to tell that story because from that perspective, it's we could have a week of A's, we could have 6 weeks of D's. I mean, it's not limited to just one particular encounter from that initial or subsequent, right?
That's
Not
correct.
so
The other
confusing.
thing the other thing that I think people, many coders have a misconception of is it's driven by global days. And patient comes out of the global period and, well, now it's none of these. And not really. The
Right.
other thing, when we come out of our A and our D, I think our delayed healing, our non-union, our malunion, they're pretty straightforward, sort of.
Hmm.
Where we get into a little bit of a problem there is you have the patient that didn't present initially. Very common in patients who have fractures of their scaphoid. So they fall, they have an injury, they think they quote sprained their wrist, so they don't go into the doc. And 4 or 6 weeks later, the wrist still hurts, so they finally present. X-rays are taken, and they have a fracture of their navicular. At this point in
Hmm.
time, the provider is probably going to say they have a delayed union or a non-union, but they've never been seen for the problem before.
I
And
had
if
that in my foot once, Ruby.
did
I
you?
had that happen with the navicular bone in the foot.
That's really
That
unusual.
Yeah.
Wow, really
I had
unusual.
gone to urgent care, and urgent care said it was a sprain. It was still symptomatic, still symptomatic, still symptomatic. Finally got to orthopedist who did advanced imaging, and they were like, "Yeah, you have a non-union fracture."
Wow. Yeah, and so if you don't pay attention to how that seventh character reads, your gut instinct is I have a non-union, so I'm going to code it with my non-union seventh character. But if you read it, that is subsequent.
Right.
So that very first visit becomes an A, which really distorts the problem for the patient. And then
Absolutely.
you go to non-union, and coding clinic says, and then throughout the rest of the course of the treatment, you continue with non-union. So you're never really able to visually show in your coding that this is now healing, because I'm saying forever and ever they now have a non-union.
That's
What have you experienced with that, Christine?
Well, personally, that's what the way that it's always been documented as a non-union, because it just never healed again. It never went back. It's thank God it's not symptomatic anymore. I don't notice it. It doesn't bother me, and unless, of course, as I get a little bit older and I'm starting to realize that any bone that you have abused over the course of time has a tendency to come back and voice its opinion in later in life in the form of
Hmm.
arthritis. So fingers crossed, I still have a few more years before that ugly thing rears its head. But every time that I did have to get treatment for it, it stayed as that non-union. So that's what I'm personally seen.
Yeah. And when in a risk standpoint, they very commonly will take the patient in. They might treat them still in a cast for a while, but it's
Hmm.
not uncommon for them to go to surgery and have a bone grafting for that non-union. But they continue to stick with that non-union diagnosis despite the fact that they are now healing that fracture. The
Yeah.
other thing that I've been seeing is a not strong understanding of that seventh character S, our sequela.
Uh-huh. Exactly.
More commonly, probably in our T codes than in our S codes, but in both of them, with the understanding that my sequela can't ever be the first listed diagnosis
Right.
code. And I have to have what is that sequela that I have? What is the problem that exists? And that problem is then, is it related? Does
Right.
my physician, my provider indicate that it's related?
I
And
always say that it's when you look at the sequela, it's a new problem that is related to an old problem. So you would code it that way. What is the new problem? And then what is it related to? And again, documentation guides us to that code sequencing. It tells us it's arthritis from the non-union that Christine got many years ago. But it tells that story. And we see that in documentation. So like you said, it's difficult sometimes for people to understand that that S can't ever be primary.
Right. I think that where we struggle even more is when we get into the T codes that are complications. So we
Hmm.
already see that as a new problem. And so our gut instinct is we're going to use that T code with an S because that T code is a complication that is a sequela of. And we have to get ourselves to understand, and I love the way you stated it, this is due to this. So what is my current problem, and what was my origination problem? I liked how you related that.
Oh, because I want them to treat the arthritis that's symptomatic today, and I don't want them
Correct.
to focus on how it happened because that could be embarrassing. Um, honestly I think back to all the injuries that I've had, and I don't want to have to rehash that with my doctor. I mean, yes, let's address it that that's probably what happened, but let's focus on the arthritis that is present today.
Love it.
One of the other things that I see a lot, especially with new coders, is the confusion on those superficial injuries
Mm,
where we have a fracture or we have a wound, and of course that wound is red, it's inflamed. Maybe there's bruising that happens a lot if there's an injury there, and I think when I talk to these students, I have to ask, are we treating them from that perspective? Road rash. Oh, it's awful. But do we treat road rash? No, we feel sorry. We clean it up and we tell them don't get it dirty and it kind of heals. The fracture is more important today. The wound that needs to be repaired is more important today. The bruise is going to go away. It's normal, unless, of course, unless the documentation says that there's something more, that hematoma needs to be drained or it needs to, right? But
right.
superficial things, that's not the focus today. We've got bigger fish to fry.
Good. Yeah. I tend to agree. I tend to see that same thing. I like your concept of looking at what is really the problem that we're looking at, and is that other problem that, yes, they say they have, are we doing anything to it? And is it maybe really a result of that first problem that they had?
Hmm. Absolutely. Absolutely. I see that a lot too. Another thing that I think that gets confused are burns. I think people don't remember that we have a difference between a thermal burn or a chemical burn. And I think that's really important that people understand. And the guidelines actually give us that distinction when it comes to burns. There's some examples in there of burns, and not a sunburn. I live in South Florida, Ruby, so we typically see in our urgent care centers and even in our emergency departments, when people come from the north and they think it's wonderful to go spend a day at the beach, and our sun can be absolutely brutal, and I've seen them in the hospital because you've traumatized the skin, but that's a sunburn. And there's a specific guidance in there that says sunburn doesn't count. Right.
Which is kind of unfortunate if you think about some of those. My husband was like that. My husband was had a little of red in his hair, but his skin was very fair. He
Hmm.
was very, very sun sensitive. It did not take him long. I used to tease him when we would go to Panama City Beach and he would have his shorts on. I'd make him lay down in the sand and say, "Let's see who's whiter." Um,
Right.
but he would get sun poisoning with very
Yeah,
little exposure to the sun. And so I think it's a little unfortunate for us to not be able to look at that in our coding. But
absolutely.
I do agree, we need to, the guidelines are so extremely important on our burns. They guide us in so many different ways. They guide us in how to be able to combine our codes. What codes do we code separately for? What if we have multiple different levels of burns in the same area? How are we supposed to code those? Do we code them all or don't we? As well as when do we use those other funny codes that relate to total body surface area? And our guidelines have to tell us that.
I often think that the rule of nines is not taught enough, and I almost kind of look at it as, well, here, I'll tell you what I do. So I have this crush on Jason Momoa. I think he's like the most yummiest man out there. Um, and I want to figure out, he's got all these tattoos. How much of his body surface is actually tattooed? So I'll use the rule of nines just to sharpen my thought as I look at, okay, maybe that's just too much for this podcast. Anyway, but trying to figure out how much of the skin is affected, either from tattoos or burns or whatever the thing is. I use that just as a tool for myself, right? To try to remember those rules of nines, because we do use that in reporting the body surface amount that is burned and what's the depth of that burn. So maybe, we have a 9% that's third degree burn, and we have 18% that's second degree burn on a patient. And that's really important. The deeper the burn, the more extensive amount of skin of the burn, the more complex that case is going to be.
It's interesting to me as well that of our rule of nines, we have a table in CPT. We don't really have anything in I-10. Unless I have just not looked at it as intensely
No,
in recent times. But
some
I
publishers
see
do,
my
Ruby.
percents, but I
Yeah.
haven't seen it.
Some publishers do. And in the absence of that, I always make a note in my ICD-10 book that says, go to page so-and-so in the CPT book to see the rule of nines. And in CPT, I actually write the percentage on those nice illustrations that we have to remind me of what, the top of the chest is 9, the bottom of the chest is 9, each arm is 4.5 on the front and the back, so it comes to 9, right? I'll do that and make that connection so that I can easily find that information.
That's smart. I've also found that even though I'm really good at math, when I'm under stress, I'm not so good at math. And so I like having tables that make me not have to think as deeply when I'm trying to get an answer quickly for someone. And that's a very smart thing. Marking it on there, you're not having to remember and think, oh, this is this much, this is this much. I have
Right.
it there. I might still have to do that little teeny bit of math, um, but it still helps us along the way.
Absolutely. Absolutely. Let's see. I'm trying to scroll through these guidelines too to make sure that we touch on some of the more challenging areas. Poisoning, adverse effects, poisonings, underdosing, toxic effects of drugs there. I think that is also very interesting, but I think we need to understand what each one of those categories are when we're talking about a poisoning, where it is unintentional or intentional or assault. What does that mean when someone, and so very interesting.
I agree. And also understanding what our default is supposed to be.
Yeah.
And our default is not always the same all the way throughout those sections. So we need to make sure, again, that we look at the guidelines. And because I don't, I'm in orthopedics. So
Mhm.
I do ortho pain, those types of things. We don't deal a lot with the poisonings. We might deal with underdosing, but we don't deal a lot with poisonings, some adverse effects. So because I don't do it all the time, I need to go back and I need to refresh myself on the guidelines. But what we need to understand and we need to remember is we have to remember there is a guideline there and go
Right.
back and use it. So I don't, I tell myself, no, I don't have to know intimately what every single guideline says, but I need to be aware that those guidelines exist. So when I'm working with an area that I don't do all the time, I look at those guidelines to make sure that I'm doing the things that I'm supposed to be doing.
Absolutely. And especially when it comes to the drugs, the guidelines actually have really great examples for us to reflect upon, to see exactly what category does that fall into. So like you spend a lot of time in orthopedics, but someone who maybe is in another role where a patient could possibly, I think rheumatology often deals with a lot of poisonings, with some of
Yes.
the medications. And then, of course, as we get older, I mean, I don't know about you, Ruby, but I'm just going to be full disclosure. I have to have the little box Sunday through Saturday so that I can tell whether or not I've taken my meds today. It only took one overdosing of taking the medicines twice in one night to make me use that box because I couldn't do that. Um, so there's a lot of great examples there to explain to us when it's an adverse effect. So they took the medicine appropriately, but you had an allergic reaction, or if it is an actual poisoning, if it falls into that poisoning box there, that improper use or the abuse, the dependencies that might also come with overdosing.
Good point. It was
Um,
also nice to see this year in the guidelines, in the past we were told that we didn't code for underdosing. For
right.
them to now start recognizing the fact that that underdosing can actually have an effect on the patient, and to have changed the guidelines to now allow us to go ahead and bill for the underdosing.
Because there's a lot of medications out there that I don't know that patients truly understand that you can't discontinue them abruptly, that some of these medications have to be titrated, and when we discontinue them abruptly, patients can experience a lot of adverse effects from discontinuing that medication. So that's I love that they added that specific guidance in the new guidelines to remind us that it happens more often than not.
Hmm.
And while providers are focusing on dealing with that adverse effect, we really, again, have to code it out so that it tells the whole story of how we got here.
I agree. Actually had that situation with my husband. They had put him on Decadron for an issue, and he had major side effects with it. We had some difficulty with communication with the provider, and he wanted to just stop it cold turkey.
Mhm.
And I couldn't convince him. So fortunately, my his brother is a physician, and I
Oh,
had to pull him in and get him to talk to him and say, "You can't do this. You can't just stop the medication." um, it was definitely a provider issue. One A and B didn't want to take responsibility for who's supposed to deal with it. um, but then they met Ruby.
ah, yeah. Isn't that something? I think that happens to a lot of us. Yeah, I know Betty and Sonal and myself and so many others in this industry that we're just programmed to look at things a little differently. I
Hmm.
thank God every day for my primary care doctor. She's absolutely amazing. And, she will ask me during the evaluation and management visit, if does this qualify? No, it doesn't qualify. Everything is fine with me. Oh, okay. Okay. Thank you. And I love that. But there's other providers out there that, I had a provider once report a 99215 for just a regular office visit where nothing had changed. There were no major conditions. It was, and I thought, how did you get to that? Oh, I deserve that. That's a whole nother conversation, Ruby. Mhm.
Yes. Hmm.
Um, Complications of care, that comes up quite a bit in injuries
Hmm.
and those external causes that talk to us about complications of care. And there's an entire section outside of chapter 19 that talks to us about complications. But within chapter 19, they do talk about those complications of medical devices specifically and of transplants specifically. So, anybody that is working with implantable medical devices, cardiology, or any transplants. So, nephrology, we see that a lot.
Hmm.
Hepatology, not herpetology, that's the reptiles. Hepatology, pronunciation matters. Um, just to make sure that you remember there are specific um, guidelines there to assist us when it comes to a complication, and that the provider doesn't need to say the word complication for it to be a complication. It is due to, and it has changed the course of, then we can see it's a complication. So pretty interesting there.
Hmm.
Now, Here's the big question, Ruby. When do we use external cause codes?
Well, it depends upon your practice, I would say, but um, you can use the external cause codes aren't just related to injuries, so they're actually able to be used with anything in the I-10 book that might be related to something that caused something else. But vast majority of the time they will be injuries, but
Hmm.
you have a lot of external cause codes that are out there related to kind of overuse type problems.
Hmm.
I am a major proponent of the use of external cause codes. Um, and one of the things that it does do is if you do have an injury, the external cause codes can very much help to prevent some of the delays that we have from our payers because they see those dreaded S codes and they say, oh, I probably am not responsible for this. And
Hmm.
so they send off a questionnaire to the patient who never answers it because they say, well, that's for my doctor to take care of. And they don't answer it. So the insurance continues to not pay the provider because they don't know if they're responsible. Versus giving that external cause says, this is what happened, this is the causation of it. I think the external cause codes are very fun, very interesting to be able to use. And when we use them, we need to remember we can never use them by themselves.
Hmm.
Sometimes we want to, but we can't. We always have to have a causation, and we can't use all of the different variations that we have. So we can use the causation anytime the patient is being seen. And we have a seventh character that gets attached to all those causation codes. That's very similar to our seventh character that we have in chapter 19. But then we get into, well, where did it happen and what were they doing?
Hmm.
And what activity were they involved in? What place were they? That's the first time and the first time only.
Right.
And I think that we don't always remember that, and we kind of want to tend to glide that in as we can.
But there is a guideline for that. Ruby, I wanted
There
to go
is.
back to what you said earlier about how it happened relating to an insurance company sending out that coordination of benefits letter. And I
Mm-hmm.
know that when I was working in practice, and I also had a billing company, and we did a lot of denials that would come through, and they've requested additional information from the patient. And I used to think, boy, you know what? That's a racket. They're delaying payment of my claim, but you just made my light bulb go off. It
Mm-hmm.
probably was related to a diagnosis code that was submitted on a claim that triggered that insurance company to say, there's a good possibility I'm not at fault. There's a possibility that there's an error on the claim, that it was auto related or work related or even a liability related,
Mm-hmm.
because they drank hot coffee from McDonald's. Anyway, I don't know if you remember that way back in the
I
day. There
do.
was,
I do
yeah,
remember.
a lot of the
They used to
young
put a
people
sign
didn't.
all the time. The coffee is hot. No joke.
I hope it's hot. But now we have iced coffee. So anyway, but I think that's important for people to remember. I often say that the insurance payers, they only see what is on the claim. They only see that diagnosis and that procedure code and then the relationship between them. So oftentimes they have more questions based on that simple amount of information that was provided to them. And you made my light bulb go off. And now I'm
Yep.
going to look at that completely different. I bet that sometimes we might see orthopedics have that denial more often than others.
Yes, we do. And we had the same thing. And for a few years, I was out of orthopedics and working in radiology. And
Ooh,
it was the same thing. Both the radiology groups that I was in, the coders were told we never code external cause and because it doesn't get paid. I'm like, well, it's not a payment code. It is an information code to add to that. And so I slowly got them to understand it. And I was even able to show them we got paid for this.
right,
It wasn't 6 months from now, but you
right.
actually got paid for it because we told them what happened in the injury.
You
You have a
mitigated that
patient,
potential denial.
right? You have a patient with a puncture injury. We've got bite codes in chapter 19. Maybe I want to tell them what that bite came from. Was it a human? Was it a dog? Was it a cat? And particularly from cat bite injuries, because cat bite injuries very commonly end up going to surgery. because the organisms for some
Yep.
reason, cats more commonly than dogs, there's an organism that cats have that tends to cause an infection. And so people who get cat bites, particularly on their hands, end up with tendon inflammation and an infection in their
Yeah.
tendons. I'm giving you that information. I'm now also telling you why I'm treating this patient for a longer period of time.
But also, I've seen it with animal bites. If they are domestic pets, that claim might actually be a liability claim. The homeowner's insurance might
Oh,
be the
good
one
point.
responsible. Yeah. So those external cause codes are really going to help. It was in their own home, or was it in the home of somebody else? And that could tell more of that story with those external cause codes.
Yes, very much so. And some of them are just kind of fun,
I know.
like plucked
Spontaneously
by a chicken.
combusting, plucked by a chicken, or my favorite is always spontaneously combusting while water skiing.
Oh, yeah.
There is a code. Optum was showcasing that code for a long time, because I think all of us were like, can that happen? I don't really know that can happen. I've water skied before and I never felt like I would spontaneously combust.
Would think they would have to be going awfully fast.
Yeah.
Yeah. Well, my two favorites, one of which they removed, but initially, when the codes came out, we had sucked into a jet engine um, with an S attached to it and a D, and I'm like, well, maybe. But they also had the decapitation code, where, and with my
I'm sorry, that's not funny,
decapitation,
but
I had a seventh character of D and S attached to it, and I
what?
was, yes, we did. And I believe that decapitation external cause code went away, but there was a D and an
I
S
hope so.
actually attached to it. And I was like,
Crazy.
I don't see how this is possible.
Yeah. And we have enough codes in the book. Please don't give us codes that are just not possible.
Correct.
Ruby, our
But
time
there's,
is done today.
okay.
I've had the best time ever. This is one of my favorite episodes, I'll tell you. Um, I absolutely love these chapters, especially because you get to really tell a story with the codes that belong in both of these chapters, 19 and 20 there. And I always find that to be a little bit of fun, especially the external cause codes.
I agree. I appreciate you inviting me, Christine.
Sure. And I can't wait. We're going to see each other in New York at the Business of Medicine retreat. Those of you that have not signed up yet, there is still time. There's still availability to come to the Business of Medicine retreat. We have a discount code for you. We look forward to seeing you all there. Come and hang out with Ruby and I. It's a very unique experience. If you've never been to a retreat setting, it's not like any of the conferences that you may have gone to in the past.
Very much agree. It is a very laid back experience, very non threatening experience. So, many people that go to conferences are very concerned because they're new and I don't know anything. But you don't get that experience at this retreat at all. No question is ever silly, no
Yeah.
question is ever dumb. And some of those ones that we think are that way actually make us all think of things in a little bit different way. It's a fabulous experience.
And it's my birthday weekend. So
Oh, that's even better.
anybody wants to hang out for my birthday, okay, no pressure, but all right, guys, thank you so much. And we will see you in 2 weeks. Thanks again, Ruby.
Bye, everybody.
Thanks for watching.